Lord God, we give you thanks for the opportunity we have to learn together and to um, be, be intrigued and encouraged and challenged by what we hear tonight. We ask that you would guide each of our presenters, that they would be able to share clearly and we would all learn from this experience. In Christ's name we pray, amen.
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 Hi, Stacey.
Hi, how are you?
Good, good. I'm thankful that you're joining us tonight.
Oh, glad to be here. Thanks for inviting me.
Okay, so this volume is good?
Yep.
Okay. And we're recording the session. Is that okay with everyone?
Yes.
Speakers, everybody all right? We do that? We are putting them on the Presbytery website so that folks can avail themselves of it afterwards if they're not able to be with us. There's 6 people in the waiting room, so we can wait a few more minutes.
Hi, Mudia.
Hello. Hey.
Hey, thank you for joining us tonight.
No problem. Thank you for inviting me.
Plug my computer in so that won't be a mishap. Oh, Frank?
Yes.
You had said before that you were going to cut registration off or entry at a certain point. We were wondering if you could wait at least 5 minutes. Did you have that in mind to do tonight?
Oh, definitely. I usually wait till we're halfway through because
Okay.
people will show up late. And also the problem there is that, excuse me, if someone accidentally gets dropped or drops out, then they can't rejoin. So I wait a good long time to lock it.
Okay. Someone had mentioned they had a little difficulty last time, and I thought maybe it was because they were locked out. We don't have many in the waiting room, but it's 6:30. We should probably start on time since we can. We're all here. Everybody okay?
Shall we admit everyone?
Sure. I'm ready if everyone else is okay.
You can say hello.
All right. Good evening, everyone. Thank you for joining this third installment of our Be More Human series. It is just 6:30 and we're expecting about 48 or so folks. So we're going to wait just a little bit longer, but thanks for joining us tonight. We'll be right with you. Okay, we're gonna get started. I have been told a couple of times this evening that my voice is not carrying all of that well, so please feel free to raise your hand if you find that you're not able to hear very well. My name is Annette Snyder, and I am co-convener with Kenny Walker of the In the Loop Ministry Group of the Presbytery of Baltimore, and we are sponsoring this series of discussions that we're calling Be More Human. And specifically this
Excuse
evening,
me, Annette.
yes,
Excuse me, Annette. This is Kim Baker. Hi. I can't hear you. I can barely hear you.
okay, thank you.
Thank you.
I am going to be talking above my usual voice. I hope I don't come off as yelling at you, but I will try to do better. Is that better?
Yes, thank you.
Okay, thanks. So tonight we're going to be discussing the legacy of enslavement in regards to health. Health is a topic that is huge in our lexicon these days, and we'll be getting into some of the current and historical issues that impact where we are. But just as a review for anyone who might just be joining us for the first time, our vision for this series is to disable our institutional biases, those things that are built into our society that sometimes we're not even aware of, but we need to be aware of them so that we can dismantle racism. And we need to work on our awareness and understanding of issues so that we can get rid of hateful rhetoric and we can injustice. So here we want to speak to each other, listen to each other, think about what we are hearing, and hopefully act in a positive manner moving forward. These first 3 sessions were based on a series of articles in a New York Times series called the 1619 Project. And it was called the 1619 Project because it was published back in August of 2019, which was the 400th anniversary of the first recorded transatlantic slave ship that arrived in Jamestown, Virginia. And as an introduction, Nicole Hannah Jones, who is the leader of this effort, wrote, "Our democracy's founding principles were false when they were written. Black Americans have fought to make them true." Now, this series is not without controversy, and we're not going to defend it or not, just for the good of the cause. This is not about our country not being the great nation that it is. It is about some of the founding principles that were that were not human, equitable, fair, just, and we are a just society. So these are principles and ideals that we need to address. Now, those of you who are haiku lovers, don't criticize me too much because I didn't quite make this right, but I think this packs in a lot of the things we want to talk about tonight. So unequal treatment, disparities, underserved, some say undeserved. So here we have unequal treatment was a seminal work by the Institute of Medicine in the early, about 2004, I think, that was a seminal piece on the effects of unequal healthcare access, healthcare delivery, healthcare seeking opportunities. And we know that these things lead to disparities in health, and we'll be hearing a lot more about that tonight. But disparities in terms of the gradient of those who have good health and good health care and those that do not. So sometimes we refer to the populations that are impacted with health disparities as being underserved, underserved in that they don't have equal opportunity and access to health. And I have written here again, some say undeserved. There is an element of thinking that goes that poor health is something that is brought upon themselves by an individual's behavior. And And we know that there's a lot more to it, that social circumstances, socioeconomic status plays a large part in health disparities. So just a few words to frame our discussion tonight. So we had 3 fabulous speakers. I won't read their bios in their entirety. Dr. Corey Henderson holds a doctorate in public health. And I'm reading this because some of us have dialed in and cannot see this screen. So actually I may need to read this quickly. Dr. Henderson's research is rooted in social and behavioral sciences with an emphasis on historical trauma's influence on the health of African Americans. Dr. Henderson has a background in information technology, qualitative research, health policy, and public health. He believes that healing is possible for every human being that acknowledges injury. Inasmuch as healing is a process, it is a process to restore health, complete and holistic. We're also joined by Mudia Uzzi. Mr. Uzzi will speak about his project titled Mask On, Increasing Education and Access to Cloth Masks in the Greenmount West neighborhood of Baltimore City. Mudia has a Master of Science and is a PhD student in the Department of Health, Behavior and Society with the Johns Hopkins Bloomberg School of Public Health. And Ms. Stacey Stevens is a licensed clinical social worker, certified and is the director of the Be More for Healthy Babies, Upton Druid Heights program at the University of Maryland School of Social Work's Promise Heights initiative. She has over 25 years of experience in assisting underserved women, there we go, underserved, and children to help them gain access to medical and mental health services throughout Baltimore and DC. Mrs. Stevens is a clinical instructor in the University of Maryland School of Social Work and an adjunct professor at Morgan State University's School of Social Work, where she teaches and inspires future healthcare professionals. She was a governor-appointed member of Maryland's task force to study perinatal mental health. She is also a certified diversity practitioner, which enables her to help individuals, groups, organizations, and communities effectively manage cultural differences, influence system change, and create equity in the healthcare and educational sectors. Ms. Stevens is an international speaker, a sought-after facilitator, and a strong advocate for children, families, and communities. Her areas of research interests are health and well-being of vulnerable populations. And I want to go ahead now and welcome our speakers and engage you in listening to the important message they have for us. Dr. Henderson.
Good evening, everyone. Without delay, let me share my screen so we can get started here. And I'm going to take a few minutes and walk us through. Give me 1 second, please. I have to share my screen first, actually. Yeah, so I'm going to walk us through today a little bit about how we got here. And in the process of how we got here, I'm going to share with you a little bit about health disparities in the 401 years that we have been here in this country, and how we've transitioned to a place that health disparities actually exist. I'll be happy to take questions after the presentation's over, but let's get started. So today I titled this presentation 401 Years of Disparate Health. And this is because of 1619. So I talk a little bit about today, slavery to quasi-integration. And we say quasi-integration is because in my research and in my thesis, what I discovered is that many of the interviews that I did, people thought that they were integrating into communities only for those communities to deny them entrance or deny them acceptance. So we saw a major movement of communities when Blacks moved in. Here I talk about the idea that systemic racism is actually in the root of who we are as a country. And this is a graphic, you can find it on my website, but the whole point of the graphic truly is that if you start with systemic racism, then the rest of the tree is going to sprout out from it. We have economic deprivation, physical abuse, psychological abuse, segregation, forced displacement, and cultural dispossession. And what you're going to discover as this presentation goes forward is that policy moves people. As much as people like to move, it's actually policy that is causing us to move. So here we go again, health disparities. Well, what is a health disparity? It's a difference in the incidence, prevalence, and mortality of a disease and the related adverse health conditions that exist among specific population groups. Now, tonight we're talking about Blacks, and Black is it's a derogatory term in a sense, but it actually can encompass other people of color. And I say that because other people of color include the mixing of races. You don't live somewhere and not integrate with the people. Some of the World Health will tell you, and the World Study will actually let you see that when Hannibal took 90,000 Africans across the French Alps into southern Italy, then they integrated with the people. That's why Sicilians have really dark hair, and their skin tone tans very dark, very quick compared to other parts of Italians. So anytime you have a group of people living next to people, the more you get to know them, the more you get to love them, the more you get to see them and their individuality, the more you connect with them, mate with them, and build a family with them. And since this is a church calling in Psalm 137 where they cry out about they don't want to sing a song of joy because they are captives, they were used to singing songs that they were the one capturing. And that fear of remembering reminded them, going back to where people love to talk about the God will prosper you. The idea of health disparities is we need to settle into where we are, make the best of where we are, so that then we can integrate and become a community. But health disparities is the opposite of that. It actually says that you've moved in, but you really never fit in. So here we talk about the different groups: gender, age, race, ethnicity, education, income. Those are outcomes, social class, disability, geographic location, which we're going to talk a little bit about tonight, and sexual orientation. Policy moves people. Well, there was a policy at one time that those who felt as though there was nothing in Africa but darkness, late 1400s, early 1500s, you see that no one really moved past the Horn of Africa, and they decided to go to the Congo. They didn't know where they were pulling up to. It's actually near the western side of Africa where you see the Swahili coast. And when they came in, which we would call now the Victorian Falls, one of the 8 wonders of the world, these Africans saw them and said, these are the white people we always were told that they're coming to save us or they're coming to bring a message. They'd never seen people that didn't have darker skin. So they actually tried to befriend them. And you can read the story. It's a great book called The Ghost of King Leopold. And in The Ghost of King Leopold, they tell the story about the Manny Congo. He would have been like the king or reigning over the land. And his vast land went from the Swahili coast all the way to the West Central African coast. And because he had such vast land, he actually began to study with them in the early 1500s. They wrote a letter back to Europe, and they talked about how intelligent and how much this Black man had learned the Bible. He was a Christian. He could speak articulately and intelligently, and they were at the same time snatching people from under his nose and taking them and putting them on ships, walking them through the land to boats. And you'll begin to discover that the earlier part of the slavery movement was going to South America because any person that travels wants to take the easiest trip. And oftentimes they didn't take enough of their family and other people with them to establish a society. So they were overrun sometimes by the number of people. And the only way that you could enslave people is to use brutal force and to murder them. So murdering and killing required for you to keep having to go back. And because it was a short trip, they said, look, we're going to use brutality and murder as a form of keeping them repressed. And when you get to Jamaica and places like Haiti, they were actually able to overthrow their enslavers because the white men like to sleep with the Black women. So they left their wives and their families at home, and they had 100, 200 per master. And they realized, look, we outnumber them. So they overtook them. In the United States in 1619, They actually came here first as indentured servants and oftentimes came working from their relationships that they had with the British and others. And through that relationship, they realized they needed labor. And they began to hear these stories about how labor could be forced on these people. So policy moves people. Here again, I say it again because I want to make sure that you understand that point. Here we are in 1901, Baltimore City. Now, if you go look at the history of Baltimore City, and it really surprised me, in the 1800s, actually blacks and whites used to live together in the same community, lived on the same block, especially in Pigtown. Because when you first moved into the city, you wanted to find somewhere to live. And oftentimes you came in through what we would know now as 295 area. You would come up on by boat. You would walk in and you would come into the city downtown. And blacks used to live downtown in the southern part of downtown. But after the Great Fire of 1904 in Baltimore City, you saw that they picked the blacks up and moved them to what we now know as the Druid Hill area. And that community right there is where you spawn a lot of the churches in the black community. But in that district, in that district would be right there where you see like the 129 and a little lower than that, the yellow area, where you see Winchester, Sandtown. That would have been called the Black Lung Block area. Because in the Black Lung Block area, the police, the public health practitioners would not go into black communities because they said tuberculosis was running so rampant and people were dying that they didn't want to be bothered with it. And the story was told and the narrative began that blacks had the propensity to bring dirtiness and poor health into the city. And with that narrative, it helped to feed the narrative that blacks did not belong to integrate into other parts of society. Now, let's take it back a little bit. It's a great book called Sick from Freedom. And in this book, the author talks about how emancipation really didn't free people in a sense of they just got to walk out of slavery and walk into society and say, hey, I'm here, let's set up shop. It was really about how do we get the country to come together rather than how do we free these people. No one had a plan for the freed people. And if you didn't work, you were considered lazy. So they didn't want to provide services and resources because they did not want them to become major consumers of those resources and or dependent on them. So oftentimes what happened to create disparate health was they looked back at what other doctors said and what other people said. Now there was a planter in the early 1800s who actually wrote a paper in the South, and he said, oh man, these blacks, these slaves, they are made for this society. They can survive down here better than anyone else. Well, when the Civil War began and many of the blacks were dying from dysentery and they were bit by mosquitoes, they were not often given medicine off of the reading of one letter. As we know now in epidemiology, you need multiple studies, multiple reports. I saw one of the ladies drinking coffee. There are many, hundreds of studies that show that coffee is protective if you drink the right amount and don't overdo the caffeine. The idea that you need more than one study, but what they said is, hey, we actually have a article that says blacks, and the American Medical Association wasn't started. It was formed around that time, 1846. And they said, we actually have an article that says blacks are made for this society. So they didn't share their medicine with them. And more black soldiers died from not having the proper medication off of the narrative that was painted around their health. This is 1918. You see the annexing of more land. And that land was formerly in part of Anne Arundel County and also Baltimore County. And that's where you see Morgan State University actually would have been what we know of now as Morgan State University, would have been in Baltimore County. That Hill and Road area, that Cold Spring area. Roland Park would have been in Baltimore County. So 1918, you see the shift in the map to get more land. They didn't know what to do with it. If you drive up Perry Parkway in Baltimore City, you see like this really quick highway or speedway, and then it just stops. Well, that's the land where you got the golf course right there, and no one knows what to do with that land because it was annexed. Here's the Baltimore City redlining map. So you saw how the city became the city. Now you see how the city was divvied up in the late 1930s, early 1940s, when they came and said, there are certain areas we're going to lend to, certain areas we're not going to lend to. And those red areas are the areas where you could not get a loan. And those areas were specifically pointed out because they were Black areas. And the sad part is when you read the research, you actually see the government participating and drawing these maps. And there are maps of just about every city where Blacks lived. And I'm gonna get to that in a moment. But you see the maps that actually show disparity in health. They're tied to what we call social determinants of health, which I'm gonna talk about. So here we go. What are social determinants of health? They are the conditions in which people are born, grow, live, work, and age. Social determinants, social, how we interact, determining your health. So these circumstances are shaped by the distribution of money, power, and resources at global, national, and local levels. The social determinants of health are mostly responsible for health inequities, the unfair and avoidable differences in health status seen within and between countries. Now, many people don't know about the Oblate Sisters of Baltimore, but the Oblate Sisters of Baltimore actually started an organization here off of they left Haiti, they spoke French, and they were really integrated into the Catholic Church. And it just so happens that the French minister who was sent here, the French priest who was sent here, also naturally spoke French. And they meet up in Baltimore, which was actually known as the Rome of the United States. There are so many churches in Baltimore that people came here for religious study and institution. And you saw them starting to want to educate Black students and Black children after they left from the revolution and the overthrow, the coup d'etat in France, in Haiti, once owned by France. And when they came to Baltimore, they were allowed to start up this school. And because the school never expanded after the death of the gentleman who would write back and forth to the church for them in Rome and the French leader, then they were kind of slow walked into building the community to help educate. But the Oblate Sisters of Baltimore would have been specific to a definition of social determinants of health. And I say that to say they were focused on a specific group of people, a specific area of people, and a specific circumstance of people. They were educating them in basements, in garages, anything they could to give education to these students in Baltimore. And that's another book, the Oblate Sisters of Baltimore, if anyone's interested in reading that. It's a great story about how the efforts of these women had to be discovered later because they were not writing letters to one another like the Sisters of Mary or the Catholic churches or the Catholic schools that we know of now on Northern Parkway and Loch Raven and other schools around. Here's the census block from 2010. Now, people look at this and they say, what is this? This is craziness. Well, the craziness is all the Black you see is where people live. All the white you see is where nobody lives. And that's what I mean by policy moves people. When you start getting to the middle of the country, there are mostly just open land and they're mostly just white people. I mean, the percentage of Blacks is so low. And I said this, and someone said this in their prayer. It's the idea that until we live around people, until we integrate with people, until we see them, I don't care if you voted for Trump or not, I respect your ideas and your reasons because I don't know you well enough to make a decision about why you may have voted for whom you voted for. But I should respect you enough to hear your position. If we don't integrate with one another, then we will never be able to get to a place where we see each other for who we are. Now here's the different map, the colored map. What you see here is the green is where Blacks live. The blue is where whites live. The red is where Asians live. You see them all up and down the California coast around San Francisco, San Diego. I mean, it's not that far from Asia. The Hispanics, you see them kind of centered around the southern part of the country, and Blacks sprinkled throughout. And if you ever zoom in on this map, you'll be able to see that Blacks have sprinklings of communities, such as like Chicago and Minnesota and other areas where the Black population is really strong. But what you see there is the movement of Blacks was not too far off from that of slavery time. And that's the interesting part. We always talk about the mass movement of Blacks, but there were so many because they were literally running out of people. And when slavery ended, meaning you couldn't bring more boats into the country, they actually just moved people from the South, from the North to the South. They shackled them and moved them from the North to the South to make room for them to work. And then you move to the enslavement of people through the prison systems. Now that you saw that map, you can take a look at the map of where the money for the Pavement Protection Act went for organizations and businesses. You can actually go out and do a search by zip code and see what businesses applied for what money. In Baltimore City, specifically in Maryland, African-American organizations were less apt to apply for government money. I mean, that if you just do the search, you'll look, there are car dealerships getting $500,000 to $1 million, saving jobs. Some of them put that they saved no jobs. They were just given the money. And what the banks did different was the banks realized that they were getting a percentage on the larger loans that was bigger than the percentage on the smaller loans. So they gave out the loans that people asked for that were $750,000 or $1.5 million, keeping more money for themselves. And communities that had lost trust and that were disparate in their economic status were less apt to go and apply for the money. Here, we talk about the work that I did to look at trauma from a dominant group to a subjugated population. Well, there are 4 buckets. There are 5 buckets, really. Segregation, serial forced displacement, physical and psychological abuse, economic destruction, and cultural loss. And these are the buckets where the policies fit in to the 5 facets of historical trauma. Now, I wanted to show this because what happens is people forget that trauma is transmitted through storytelling, direct observation, behavioral modeling. What do you do in front of people? They're more apt to do the same, especially your children, and your neighborhood and village condition. Many of us know about the broken windows theory, where there's a broken window, somebody throws down trash, no one cleans that up, no one fixed the window, then they spray paint, and it just becomes a dilapidated community. But the broken window theory was actually used for many of the stop and frisk policies that we know of today, which have been debunked as helpful. But it led to the idea that neighborhood and village condition does matter, even though people are moving into communities that they're just trying to survive. So what did I learn in my research? Well, one, that many Blacks feel that whites have all the benefits. So they're like, what's the point? What's the point in trying? Second, that Blacks learn to make do. The idea that, oh, you don't need all of that. You don't need a better job. Why are you going to college? Ain't no jobs out there for you anyway. So we learn to make do with what we had rather than desiring more. And then the idea that if I'm working, it's more than a job for me. For so many single mothers right now who work, they're working 2, 3 jobs to provide for their children because the Black men or their husbands are now in prison and or gone, or the relationships are broken, all pointing back to historical trauma, because how we interact with one another does affect our relationships. What has happened to you during your formidable years, which are taught by your mother, which are taught while she's pregnant, all impacts your ability to function in society and to function in a healthy way. And I'm going to wrap this up, coming up on my time. So here's some health disparities that you should take note of. Black women die 3 times more often giving birth. And this is based on the pregnancy rates of death for every 100,000 live births. That makes no sense in a country that we consider a country where we have great health or great healthcare systems. African Americans are dying at a higher rate of COVID-19. And this very quickly, the reason why you see 17.7% is because where COVID-19 has been captured, it's Blacks make up 17.7%, even though they're only about 13.2% of the overall population. And because of that, there's no reason why Blacks should be double in death than those of whites. But what you're understanding and looking at this is historical trauma, health diseases, stress, systemic racism, all lead to diseases of inflammation. Diseases of inflammation cause your body to feel like it's always under attack. And before I close out, I'm going to tell you a quick story. But here, African Americans, again, if you look at Blacks, they have a higher rate amongst those of unemployment. The median household incomes, again, of other races, of Blacks, is much lower. That's, again, how are we here 401 years? Because we don't have health and wealth to pass on. So if I have nothing to pass on, then the opportunity for me to build wealth, I'm starting from nothing every generation. Black home ownership rates remain the lowest in the US. Again, going back to what I just said, if I have no wealth to pass on, this is painting a bleak picture, but there's hope. Black men and women live shorter lives. The stress that we cannot account for, it's something that you can't see. It's palpable, but you can't see it. Black poverty rates are more than double that of the white rate. It is something about slavery that is the starting point for the Black experience in the United States. And if we don't take note of the 401 years of trauma that have impacted a group of people that have been here trying to survive and have always walked up to the door and been told, you can't come in, go through the back, in a metaphorical and a literal sense, it does have an impact on our health. And then this is the rates of the African Americans or the Blacks inmates in state prisons. The only one that we're the top in are all the negatives. So here's a quick story. I'm going to close on this as I stop my share. Here's a quick story. A wildebeest goes into the wilderness and is born about 3 days old and is about probably about 70 to 100 pounds when it's 3 days old, and he can walk and he can move on his own, and he can go about. Well, this wildebeest decided after about a year that he was hungry after the migration. This is usually like around the springtime, and decided to walk away from the protection and the cover of the rest of the wildebeest. In the process, the cheetah jumped on his back. He kicked the cheetah, ran off, and was able to get away. But he had scars, and many of the scars that he had, the other wildebeest couldn't see. But because he's a wildebeest, he couldn't really say what his trauma was. He just knew he was always scared to go eat more. He was always scared to go and really venture out. So he got less exercise. He ate less. He gained weight, but he didn't gain muscle. He was bigger, but he wasn't stronger. So the next time the cheetah came, about 10 years later, every time he saw the movement of the tall grasses in Africa, he got scared. So he ran back on the inside. The other wildebeest that were growing up with him always looked at him like, what's wrong with him? There's something different about him. He never plays with us. He never jumps around. He's always a little standoffish. Well, one day the wildebeest decided to move, and this wildebeest was running with them, but was slower, pointing back to the original trauma. He was slower because he ate less, he exercised less, and he had less opportunity to benefit from being around the rest of the pack. And my question here as I close out is, how many of us are wounded in a way that it is causing us to have health disparities in our own way, psychologically or mentally, especially in the Black community, where we show up to participate, we're there, but we're really not there because we can't fully enjoy the experience of being there. And that's the point of health disparities. When we add it all together, we're physically there, but we don't have the ability to enjoy the presence of being there. Thank you all. I'm gonna pass it back so that the next presenter can present. And I look forward to the end of this so we can have a conversation.
Well, thank you, Dr. Henderson. I think you have done an outstanding job of setting up my presentation this evening. You have already covered quite a bit of ground of what I plan on speaking about. And so as I share my slides, I want to let you know that I am going to be sharing information about how structural racism and many of the housing policies that have been passed down generationally are impacting community health. And I'm speaking specifically about community health of people of color, Black people in Baltimore City. And so Be More for Healthy Babies is a citywide initiative that started in 2009, basically to improve health outcomes. And the way that we're doing this is by focusing on improving the health of babies born. So improving the health of mothers, while they're pregnant so that they can have healthy birth outcomes. This work has been led over the last 11 years by the Baltimore City Health Department, the Family League of Baltimore, and also Healthcare Access Maryland. And I have the privilege of directing the work at one of the community level, and that is the community of Upton and Druid Heights, which was mentioned earlier. And so over the last 9 years, Be More for Healthy Babies, which is a part of work coming out of Promise Heights, has really been working to ensure that every baby born in Upton and Druid Heights is born healthy and is able to live in a thriving family. And it is one of 12 communities that was initially identified as having high infant mortality rates. And so in 2009, Baltimore City had the 4th worst infant mortality rate in the country. And so what that looked like was 128 babies died that year. 27 of those deaths were related to unsafe sleep. And there was our Black babies were dying at a rate 5 times higher than white babies. And as a result of those losses that year, how that is impacting us this school year, there are approximately 10 empty 5th grade classrooms across the city because of those losses. So at that time, we understood when we surveyed the landscape of what was happening around maternal and child health in the city, that babies in Baltimore were dying largely because they were born too soon, they were born weighing too little, and they were dying because of SIDS. They were basically being put in unsafe sleep environments. We also understood that there were delays in women and girls seeking prenatal health care. And those delays were basically, they were delayed in seeking care, mostly around trust, delays in reaching care, mostly around various barriers, transportation, working, and things of that nature, and delays in receiving adequate health care, largely due to implicit bias in our healthcare system and complex referral system and practices, much of which were not meeting our moms' lifestyle needs. And so, what we have come to understand over the past 4 years is that many of the poor outcomes that our moms have experienced are largely due to the social determinants of health, which Dr. Henderson so beautifully covered earlier. And so we're looking at where you live, where you work, where you play, where you learn, and even where you worship can determine the quality of your health more so than you're going to a doctor's visit. And so one of the determinants of health that we've become extremely aware of over the last few years is the role of racism and how it is impacting the early demise of Black infants. And so we're very clear at this point in our work is that it's not race that we're seeing these differences. It's not because of poverty or education, but it's largely because of racism, where our moms and our dads are experiencing discrimination at the interpersonal and institutional level. They are also being impacted by some of that historical redlining, those racial segregation, residential segregation practices that are continuing to isolate our families, and also because of the chronic stress that Dr. Henderson spoke of and how it impacts families, women, children over the course of life. Okay, and so that's what's largely contributing to many of the disparities that we're facing around maternal and infant health outcomes. You can trace it to COVID as well, but that's another talk. All right, and so the work that I'm going to share this evening is out of the work that is occurring at the University of Maryland School of Medicine and the University of Maryland School of Social Work through a pipeline of services that we call Promise Heights, in that community of Upton and Druid Heights, and where the overall goal is to improve the health, social, educational, and financial well-being of families who reside in that community. And as you see at the very beginning where the little baby is, it is the cradle portion of the work that I direct. And we are really trying to reach actively folks who live in that neighborhood, and we are collaborating very aggressively with expectant families, families who are parenting children who have ages 0 to 3, community members, faith leaders, business owners, schools, and health practices to improve maternal and infant health outcomes. The community of Upton and Druid Heights today has about 10,000 residents who live there. 92% of those families are African American, and 63% of the children who live there live below the poverty line, and life expectancy of its residents is 56.7 years of age, which is the shortest in the city. Now, we want to talk about some of this neighborhood, and I thank you, Dr. Henderson, for sharing all your beautiful maps. What I'm going to raise is that Upton and Druid Heights is a part of the Black Butterfly. Many of us are familiar with the 220 neighborhoods that exist in Baltimore City. However, I don't know if many of us recognize that there is a big difference. There are two Baltimores that exist. One of which is aligned with the white L and the Black Butterfly. And these terminologies were coined by Morgan State University Professor Dr. Lawrence Brown, who identified how racial residential segregation was impacting not only health outcomes, but a lot of other outcomes as well. And so what we see here is this white L, where we are seeing predominantly white, high-resourced, and supported services that are present within that part of the community. And then we are able to see the print of a butterfly, where there is the second Baltimore that lives around structural differences, that is pretty much lived in by African Americans or Black folks, and it is under-resourced. I'm going to use Annette's word earlier. And so we're seeing that this is showing up and impacting racial health outcomes, and particularly maternal and health outcomes today. And not only this, you can very much see how this butterfly shows up around vacancies, food deserts, incarceration, infant mortality, and also life expectancy. All right. And so over the years, we've been very fortunate to have some successes in the work that we've done. And so at the city level, Be More for Healthy Babies citywide has experienced a reduction of infant mortality that is about 32%, where it's showing up that 30 more babies are born and are able to live beyond their first birthday, which amounts to about 30 babies over the life of Be More for Healthy Babies. We are also seeing about a 54% reduction of teen births and about a 41% decrease in sleep-related deaths, and a 36% reduction in Black-white racial disparities in infant mortality. And so some of those are some of the successes of the citywide initiative. And for the work that I have been privileged to direct, we have also experienced success. And those successes look like us not having any infant mortality losses for 2 years consecutively, having about 4.5 years where we didn't have any unsafe sleep-related deaths or SIDS deaths over that period of time. We recently just had a loss last year and this summer. So that's 2 unsafe sleep-related deaths that we experienced. And we are also fortunate to say for women who are enrolled in our program, we have had 0 infant or fetal losses for our participants. So we're extremely excited about that. More than anything, when we're thinking about some of those maps, looking at the Black Butterfly, we do reside in the Black Butterfly, but our infant mortality rates are reflecting those that are in the L area. So looking more like Guilford. And that is largely due to the work, and I do mean the collective work of residents, of our moms, our families, business leaders, faith leaders, and the like. And we're excited about that. And I'm going to share with you how we've been able to do that work. So basically in leading this work, we basically have 4 strategies that we have implemented over the years. And so the first portion is that we work closely. This work is led by our resource moms and dads who provide one-on-one support via non-medical case management services to pregnant women. And so what that looks like is we meet families where they are. We meet them in the community at drop-off centers, We meet them at doctor's visits, we meet them at WIC appointments, at libraries, and we want to make sure that we are screening early, understanding what their protective factors are that may be shoring them up so that they are not having a poor birth outcome, and also what other risk factors they may be encountering. So making sure that we are connecting them to services if they need substance use treatment, if they're experiencing intimate partner violence, if they are dealing with housing instability. We are partnering with families and connecting them to resources during that pregnancy. We are also making sure that we are connecting them with tangible resources. That may be transportation to appointments. That may be making sure that they are connected to food as well, connected to childcare resources. And we are actively working to establish trust during that pregnancy and up until their babies are 3 years of age. We are also conducting strategic outreach in the community on a monthly basis, where we are targeting and trying to identify where pregnant women exist and where parenting families are. And so these are some of our resource parents out in the community. We do pop-ups in the community prior to COVID. We do door-to-door outreach, really 4-block radius where we are identifying where there may be a pregnant woman. And we are distributing information and educating the community about what it's required to have a healthy baby. So materials around safe sleep practices, smoking cessation, how to access reproductive health, breastfeeding information. And we're not only doing it to residents, but we're also making sure that everyone in the community, from barbers to librarians to laundromat owners, have the same information. Basically, what we're doing is making sure that everyone has the same information and knows how to best support pregnant women and their families when they come in contact with them. In addition to that, we are also hosting group-based activities in the community, which are easily accessible to our families. We have prenatal support groups, postpartum support groups, social-emotional parenting support groups, breastfeeding groups, all of which are located in schools, at childcare facilities, public housing complexes, libraries, and also in churches. And on an average, each quarter, we probably have about 25 activities for our families. And so we have really been working over the last several years to not only inform, as you can see, as we're looking at a community engagement model, not only inform residents about ways that they can make changes in their lifestyle and health style and things that folks within health practices can also make changes to support our moms as they enter into practices. But we are also been actively working with the community and understanding the community and knowing who folks are and identifying their gifts, talents, skills, and abilities they bring into the community, deepening that relationship with folks. And now that we're moving to really empower and really work closely with residents. So now in our collaborative efforts, we have moved from informing to consulting to involving, and now we are deeply collaborating and empowering residents so that where residents now are actively involved in planning our events, defining our deliverables, helping us determine how we're spending our money as far as the budgets that we have. And we're seeing signs of empowerment when we see residents and moms in local organizations who are co-leading our efforts and are co-leading our activities. And we're super excited about this shift that occurred over the past 9 years. And so ultimately what this reflects is that we've deepened our trust with residents and community organizations. And we really call this to be the secret sauce of the work that we are doing. We have a community advisory structure that is actively involved in helping us figure out kind of what our outcomes and deliverables are. We have a community collaborative that's comprised of about 25 partners. They include home visiting agencies, medical practices, business owners, church leadership, and our peer leaders. They meet monthly, and they help us to collaborate and identify what our community-based activities should be. And a powerful group of community achievers who are our advocacy group. And they are led by residents, and they meet actually twice a month. And they are helping us to understand kind of some of the activities that we should be doing. And so currently we are working on shoring up and helping to shore them up with workforce development skills. So many of our community achievers and peer leaders are now participating in lactation training. They are in training to become doulas in the community. And they are also being trained to facilitate some of our parent support groups. And so we're super excited about seeing them grow as well and supporting this work in their community. So here's a picture of some of our barbers who are also actively involved in our work. We've been working with the barbers for the last 8 years. We have about 4 different activities in which we go into the barbershops strategically to connect with dads, to make sure that they have the same information that women are receiving. We inform them about safe sleep practices, breastfeeding, literacy, self-care, mental health for African American men as well, so that they can be shored up to go home and to support their families. And so they are an active part of the work that we are doing as well. Here is a list of the community assets that we discovered in some of our work that we did about 3 years ago, where we held about 20 community conversations with over 900 residents in Upton and Druid Heights. What we found out and what residents found out in those communities was that there are a lot of overlooked assets amongst those who reside in Upton and Druid Heights. And so we found out that there were many gifts and talents, and folks started kind of networking naturally at those activities and events and figuring out ways that they could support some of the work that is occurring, not only with Be More for Healthy Babies, but also with some of our other partners. We also heard from our residents some of their top 3 requests and concerns that they identified when they were speaking of what is needed to have a healthy community. They understood that they wanted to have neighborhoods that were beautiful, neighborhoods that were safe, neighborhoods where the men in their community and the boys in their community ages 14 to 24 were employed and actively involved in programming. And so what we have been doing is working with groups to ensure that that is happening. What we know is that there's a lot of stress in the community that Dr. Henderson spoke of earlier, and some of this stress is related to the requests that are here on this page. And if we look at research, Black women are about 4 times more likely to live in neighborhoods where there is high violence and high crime and high air pollution than white women. And what happens is that results in increased hypertension. That stress results in increased hypertension, which impacts maternal and birth outcomes that we are very much aware of. And so now, it is imperative that we inform our residents about the outcomes of what the role of stress and racism on their health and how it impacts pregnancy outcomes. And so we've been integrating actively meditation, breathing, and art and self-care practices into the work that we're doing. And this is just showing you a picture of some of that work. We are trying to make sure that blood pressure cuffs are at libraries, at some of our churches, some of our housing complexes, so folks don't have to feel like they have to wait to go to their doctors or to CVS to understand what their blood pressure is, but they can be actively involved in understanding what their numbers are. So that's another program that we have implemented over the last year. And so as a result, we've had to do some shifts as it relates to the current pandemic. And so we recognize that it's not just a pandemic, but there's a triple pandemic that is going on. One that is involving racism, COVID-19, and also climate change. And so during the last 8 months, strategically, we have been working to increase connectivity, and decrease social isolation by checking on the well-being of our moms and our families and community partners. And we have been doing door-to-door deliveries of household essential products to folks. We have been actively involved in delivering food from our Freedom Food deliveries, which several of the churches are involved in the community. Shout out to Brown Memorial. Okay, absolutely. And so we were feeding folks. And we have also been cheering up folks around the grief and loss that they've experiencing and some of the stress. And many of our groups have transitioned to virtual environments. And so overall, in conclusion, I want to say that we have continued this work to ensure that every baby born in Baltimore, no matter who she is, where he lives, how much money her family makes, or the color of his skin, has the opportunity to live and thrive and grow into a healthy child. And that concludes my presentation.
Thank you, Stacey. We'll be hearing now from Mudia Uzzi.
Thank you. Can everyone, I guess like, thank you for the presentation, and thank you, Ms. Stevens and Dr. Henderson, for your amazing presentations as well. Can everyone take a break to stand, stretch? It's been a minute since we got on the call, so it's a good time to take a break. 1 second, as I put up my slides. Okay, so can everyone see my slides?
Yes, we're good.
All right then, so I will start my talk. My name is Mudia Uzzi. I am a PhD student at Johns Hopkins University, and also I am a member of the Greenmount West Community Association. And so today I'll be following up those amazing talks, talking about addressing fundamental causes of COVID-19 inequities through community action. So the COVID-19 pandemic has taken an enormous toll in the health and well-being of individuals and communities throughout the United States. As of Sunday, November 15th, so yesterday, the health officials have reported over 1 million cases of coronavirus. The number of cases of hospitalizations have been rising rapidly over the past few weeks, and the death toll is nearing 250,000 people. In Maryland, the current COVID-19 picture is worrying as well. This past Saturday, Maryland reached a new high for single-day COVID-19 cases of 2,231 cases. That is over 500 more cases than the previous peak that occurred in the middle of May. The surge of the COVID-19 cases over the past week has led to government officials in Maryland and the Baltimore City to add new coronavirus restrictions on response at large gatherings. However, when looking at how COVID-19 impacts communities in Maryland and the US, it does not impact all communities in the same manner. COVID-19 is not the great equalizer, as New York Governor Andrew Cuomo or pop star Madonna referred to in comments earlier in the pandemic. To quote a Harvard historian, Evelyn Hammonds, epidemic diseases lay bare and make visible inequalities in a society. Reviewing local and national COVID-19 data, you can clearly see the racial disparities on display with respect to important COVID-19 outcomes. So this chart basically is showing the Maryland COVID-19 data by race. So the first column on the left, it shows the Maryland racial demographics in general. The second column in the middle shows COVID-19 cases. And then the third column shows COVID-19 deaths. So when you look at Black Marylanders, you can see that basically there's a health inequity with regards to COVID-19 deaths. So Black Marylanders are 30% more deaths, have 30% more deaths than expected by the racial demographic data. For Latino Marylanders, Marylanders have almost double or over double actually COVID cases compared to what you expect from their underlying demographics. And we look at white Marylanders, they are less representative for COVID-19 cases and deaths. It's really important to know that the racial disparities of COVID are present in Baltimore City specific data as well. So in observing these racial differences in COVID-19 outcomes, you might be wondering, what are the causes for these racial inequities? What sociological theory can be a useful framework to look at COVID-19 disparities? We can view racism as a fundamental cause of COVID-19 related health inequities. So what happens is that racism perpetuates the health inequities that based on pre-existing racial differentials and resources. Racial inequities in healthcare access particularly can be eliminated when looking at new diseases like COVID-19 and new treatment prevention options for COVID-19 are introduced in communities. So looking at society's past experience with encountering a new disease can be useful in understanding our current COVID crisis. Black Marylanders, particularly in Baltimore, were vulnerable to negative outcomes with the 1918 flu pandemic last century due to a combination of racist policies and practices. For context, the pandemic occurred towards the beginning of the Great Migration of Black Americans from the Jim Crow South to the northern cities. However, as medical historian Lakshmi Krishnan notes, Black Baltimoreans were greeted with prejudice, stigma, segregation policies, and violence, which were allegedly aimed at improving public health. Due to these racist residential segregation policies, Black Baltimoreans largely lived in alley districts or highly occupancy tenant houses with poor sanitation and ventilations. And so we know that basically with poor built environment conditions like these, infectious disease spreads more easily. Moreover, there was structural racism that led to the segregation of medical facilities. And so medical institutions in Baltimore, Black community were woefully underfunded and under-resourced. As you can see from the slide, Baltimore City's only hospital, which was called Providence Hospital, was overcrowded in the height of the flu pandemic in 1918 and couldn't see new cases. So during the 1918 flu pandemic, the poor built and social environment of Black community due to structural racism led to some devastating results. Although the Black community reportedly had lower influenza infection and illness compared to the average, the death rate was much higher compared to the white community. In the image that you see below, on your screen, this is an image of Mount Auburn Cemetery in South Baltimore. And so the death rate was so high for the flu pandemic that they had to build a mass grave underneath the grove of trees you see on the bottom left or bottom right hand of the image. However, the Black community in Baltimore and other parts of the US were resilient in the face of the dual challenges of structural racism and the flu pandemic. The Black press, particularly the Afro-American newspaper in Baltimore, fought racist misinformation about the flu and encouraged Black people to take precautions against the flu. The press also provided information and data about the Black experience of the 1918 flu at a time when race stratified data was limited. Also, Black nurses who were excluded from the World War I were on the influential front lines, saving lives. One life they saved included Harriet Jones, who you see on the right. She was 5 years old during the flu pandemic, and her life was saved thanks to like the brave nurses, Black nurses and doctors who helped her. So I spent some time talking about sort of how the Black Americans encountered the dual issues of structural racism and the pandemic during the 20th century. Now I'm going to shift the talk to talk about the relevant issues that of today and how I and other people engage in community action against to address COVID-19 inequities. So just to give you some background, when the pandemic started in the spring, I was super frustrated with the federal response about the pandemic. There was like a lot of mixed messaging. So you should wear a mask or you shouldn't wear a mask. And also like it was just really confusing. And then also there's like a just general lack of the federal response. So like no one was thinking about how to get resources, particularly masks and other sort of PPE to people who were either low income or struggling or the elderly. So I was just incredibly frustrated. But in addition, there just seems to be a focus on some medical professionals about explaining away the health racial disparities based on just individual behavior, like smoking or obesity or alcohol. But they weren't acknowledging the structural factors that contribute to the vulnerability of Black Americans and other groups to COVID, such as the fact that Black Americans are more likely to be essential workers, they're more likely to take public transit, which puts them more at risk of getting COVID. Also, Black people are more likely to live in high density or overcrowded housing, which also impacts their risk. And also, Black Americans are less likely to have health insurance, which basically means like less healthcare access. And so, not acknowledging these structural factors and how they influence people's risk for COVID, I found was like just pathologizing Black people, and I just found it incredibly offensive. So, in April of this year, the Urban Health Institute at Hopkins came out with a request for proposal for students and faculty to do a student and community partnership project around COVID. So it was like a COVID response project. And so basically I channeled my frustration to basically create a grant for this project. So I emailed the president of our local neighborhood association, the Greenmount West Community Association, and talked to some students at Hopkins and sort of got volunteers as well from the neighborhood association. And we basically wrote up a grant around mass response. So we wrote the grant and we won. So basically, we won a $10,000 grant to basically do work around COVID response. And I decided I wanted to do something around increasing access and education of masks to people in my neighborhood. So the Greenmount West neighborhood. The Greenmount West neighborhood is in sort of central East Baltimore, near Station North, near Penn Station. It's a racially mixed neighborhood. It's majority Black, although there's like a large proportion of white and other groups of people as well. And so when we thought about sort of what we were going to do with the project, we kind of thought about different things we could do. And these are some of the things we did. So the first thing we did was that we worked with a social designer to make a pamphlet. The pamphlet had basically information about sort of like what masks are, why you should wear a mask, and then also information on how you should wear a mask, and also like dispelling misconceptions about masks as well. We also procured a lot of masks. So we worked with a local organization in our neighborhood called Station North 2 Library, and they shifted their production over time because of COVID, and they had their volunteer sewists make 1,000 masks for our neighborhood. So on the left, you can see like their call to action. They put on Instagram for the sewists, and on the right, you can see some of the lovely masks they made. They were really lovely and amazing. They're cloth masks, and they're of different sizes, both for children and adults. And then we also started working with different organizations to do mass distribution projects or events. And so, like for instance, we partner with sororities and fraternities, particularly the IOTAs were really amazing partners. They are in our neighborhood. The National Center is in our neighborhood, so like they were been amazing partners. But also the Deltas, the Omegas, Alphas, a lot of other people, a lot of the other fraternities as well. And we just kind of like been doing different events at different places. So this event right here that you see in this picture is basically kind of a event that happened in the end of August. It was like a back to school day where people were giving different book bags and supplies to students and parents, and we included that with mask distribution. We've also identified sort of places that might be higher at risk. So as I mentioned before, places that are high density are more at risk for COVID. So on the left is the manager of City Arts apartment building, which is one of the biggest apartment buildings in our neighborhood. And so we basically did mass distribution in the neighborhood. So she's wearing rubbing the ravens and wearing her raven mask. And if you look at the bottom left of it, you see our pamphlets on the bottom left of the picture. We also kind of connected with different organizations around voter registration and census drives. So basically, at the census drives and the voter registrations, we will also pass out masks. So you can see me along with one of my co-founders of the project, Joanna, who's like below me. and some medical students from Hopkins as well, passing out masks in that event. Finally, we worked with the community association in general just to kind of do work within the community. So they have community action days where they either are doing recycling or trash or picking up stuff. And so we are doing, we are passing out masks in those events. And so on the bottom right, you can see Lauren, who's the president of our neighborhood association, in the picture wearing the sunglasses. And she's been an amazing partner as well in the work we do. So y'all might be wondering, like, what can y'all do as churches for the COVID response? So there's a church in, I guess, West Baltimore, West Baltimore in Baltimore Hill called Memorial Episcopal Church. And I just found this project basically that they're doing really amazing. They're basically doing a thing called peer coaching. I've heard it before as well, called as community health workers. And so they train just regular old people in the community to kind of like around sort of like different health issues and how to encourage the community around just living healthier lives, basically. And so 3 Black women from an Episcopal church called Memorial Episcopal Church in Baltimore Hill launched this program. The program's called Kindred Coaches. And the coaches guide, motivate, and help distress people in distressed neighborhoods to figure out how to live healthier. And the communities they target a lot are communities of color. And they have buy-in in the community because of the deep connection in the communities. And I know that y'all also have buy-in in your communities. And so that's kind of just one way you can help out your community with regards to COVID-19 or just health in general. And so, I mean, I guess that's kind of it. This is kind of like, please follow us on our Instagram. We have Instagram, we have a Twitter. I have a personal Twitter as well. And yeah, that's our project. So I guess like the next section is questions for all of us. So I'll start sharing my screen.
All right, thank you, Mudia. Well, we've heard from 3 fabulous presenters. Dr. Henderson gave us a great overview of the historical context and how present policy stems from historical events and social movements. And I think these 2 examples of current programs that are still trying to make a difference in the health of underserved and vulnerable populations are extremely important, and existing examples of how health is still impacted by racism, inequality, and government policy. So we have a few minutes. I'm going to ask if there's anyone who has something they'd really like to share, their impressions or questions or thoughts from tonight's presentations, to please raise your hand and Frank will be able to unmute you so that you can share. I remind us all that on Thursday, we will gather again together in small groups to have more in-depth discussions about our own opportunities or experiences in regard to health. You may be an individual who has always had great health care, a healthy family who's never experienced living in a food desert, worrying about employment. You have a great trusting relationship with your healthcare provider. And I think we should talk about how those are not the experiences of all people. I think we can gather together on Thursday and talk about how we might engage in some of these activities that are going on in communities around us. I will share, for instance, in the Luke just constructed its 2021 budget at our meeting last week. And one of the things that we hope to do is to sponsor COVID vaccine promotion and education and even an on-site clinic. So there are things that our churches can do, and hopefully we'll come together on Thursday to talk about some of that. Frank, are there any folks that would like to jump in here?
Hi, this is Kenny Walker. I have a question for all 3 speakers. There a way we could get the email address? I know Mudia, you had your Twitter and all that, and all that stuff, but I'm 58 years old, so I don't go on Twitter. So if you have an email address, and and that goes for you, Corey, and Stacey also, that we can get in contact with you about the subjects that you talked about, that even further, how we could get the community involved in what's going on.
We will be posting tonight's presentations on the Presbyterian's YouTube. Is that right, Frank? And we can make sure that contact information for our speakers is available as well. That's a great idea, Kenny. Thanks. Like Julia Erickson would like
Julia?
to Kate Foster Connors.
I've asked Julia to unmute.
That's a very good idea. There's a bill coming up before the Maryland legislature this coming session called Health Inequity Resource Communities, that's sponsored by the Healthcare for All advocacy group that's based in Baltimore, that's done a lot of work with funding different kinds of healthcare projects. They supported the tobacco tax being used for smoking cessation and mental health problems, et cetera. And they're looking for organizations to sign on as support. Health Inequity Resource Communities through healthcareforall.org.
Thank you. Kate.
Thank you. First of all, I want to thank all three of you. This was just really fascinating and so inspiring. So thank you for the work that you're doing. I guess my question is maybe a little unrealistic, but I'm just interested to know. I'm struck always, but especially listening to the three of you, with the incredible sort of wraparound services that are required to strengthen a community and improve health outcomes and close that gap in disparity. And so my ridiculous question is, what would it take, like really, what would it take to accomplish, Stacey, what you're accomplishing in Upton and Druid Heights, or Mudia, what you're accomplishing in Greenmount West with the Mask On initiative? What would it take to accomplish that citywide? Like, if you could just sort of wave a magic wand and make that happen, what would that look like?
Wow. Oh, go ahead.
Go ahead,
Yeah.
Stacey. No, I'm gonna let you go because I'll talk about what I'm doing nationally. But Stacey, I think kind of going from the small to the large, let's go there.
So first of all, thanks, Kate, for that question. I think we've had, one of the reasons we've had our success is because we've had a fantastic funder. Care First Blue Cross Blue Shield is dedicated to funding our program across the city, citywide, for 10 years, and they've added on additional 3 years. So that consistent funding has supported a lot of the work that we've been doing. However, that funding has been level funding. And so every year we've got to bring on and write probably about 3, 4, 5 other grants to cover the costs as we continue to expand, because as I shared in the presentation, we are recognizing how many things are being impacted by birth and health outcomes in the community. So one of the other things I would say is that we've got an untapped tax resource in our city with large corporations that reside in a certain part of the city that could really turn around some of the systemic issues that we are encountering. And so we could all collectively figure out how we can hold those organizations accountable, many of which are not involved in this work at all. So again, we are fortunate that we're doing a layered approach where we are looking at, some funders who are doing this work, but then some donations, but then out of the will of the people, as we have been moving forward and getting to know folks, and then building kind of a snowball effect and having more people involved. So that's how we've been doing it. And yes, I think larger citywide, Be More for Healthy Babies, has identified, like I said, initially 12 communities initially. And so this work is only being done in 2 communities in a very strategic manner. And so they definitely want to make sure that other portions of the city are having opportunities to have this very strategic work done in those areas. So I'll be quiet now and pass it to my.
Yeah, so I think that the question is a great question because I've been really contemplating this. And Kate, what you'll be surprised to learn is that there's a lot taking place around this specific conversation. What do we all do? I mean, at the end of the day, it's beautiful to have these conversations and to talk in earnest. But if there's no outcome, then we just basically all looking good on Zoom. And I know we all have other things we can do, homework and spend time with our children. So I've been really considering what does it mean to empower and to really define power. So there are 3 types of power. There's power to, power from, and power over. And empowering is what you guys are doing right here. It is creating a conversation that is open, that is ecumenical, and that is inclusive. And I think that first, it starts with the individual. So it's the intrapersonal and the interpersonal self-reflection. And I was reading a journal article. Yes, I'm a nerd. I was reading a journal article about Hosea. And one of the questions that the guy posed was, he said, the founding fathers did not believe in the future. And it made me pause for a moment. And he said, the founding fathers did not believe in the future. So then you got to go to the next sentence and say, okay, that was a great pregnant pause. What he said is the founding fathers, they believed it in. They didn't believe in the future, they believed it in. So the future that we want to see, we have to walk it out, talk it out, and believe it before it comes. And it kind of leads to the idea that even in art and in our personal lives, the things that we experience are actually felt more before they're actually actualized. So the vision of the chair you're sitting in, somebody had to think of it first, they had to feel it, they had to experience it before they could draw it out and make it come to pass. So that requires community-based participatory research, the work that Stacey and Stephanie's doing, and Uzzi, the work that you guys are doing around the community, really empowering individuals to take back their power and to take back their health, to take back their economic empowerment, to ask the questions. And that's why I start with definitions, because the assumption that we all speak the same language is not fair. And it really starts with having these community conversations like you're doing. So the work that I'm doing nationally, I'm actually a senior research fellow in addition to all the other things I do. I'm a senior research fellow at George Mason University under the John Mitchell Jr. program. And we have literally just started working with the Breathe With Me Revolution. You can go online, I'll put it into the chat. It's the Breathe With Me Revolution. And the work there is really looking at how do we integrate our work around trauma, racial healing, and transformation at a national level. So we're bringing in international heads that will be specifically working on how do we start commissions like those in South Africa, those in other parts of the world, that resolve us having deep conversations like this. So you're really on the ground level. Now, some of the top names are the Kellogg Foundation has already started, and they're one of the international largest philanthropic organizations. They've already started working with us around funding for archiving the work that we do, getting these stories. I'm going to be coming back to you hopefully in the next few months to start to build a partnership of how do we connect others, because this is a national movement of trying to, under Res Con 1, which is the House resolution of Congress, Barbara Lee, and 169 other congressmen and women actually signed a resolution in June 2020 that we need to initiate commissions and deal with the racial reckoning and healing that's necessary for us to become one community nationally. So I'm working on that. Alicia Keys was supposed to go and work with the NFL to get $10 million from each team. That would have been $300 million towards this work. She just came back with $1 billion commitment. So that type of stuff we're not even really talking about, but you can find it by just searching Alicia Keys and NFL, or Alicia Keys and $1 billion. Because we now see Citicorp just put out, I think they're going to commit $1 billion to the racial equity movement. There's a host of organizations that are putting up. Michael Jordan, we're supposed to be meeting with him soon. He's actually working, he's friends with the Chicago White Sox owner. He put out $100 million towards this work. So to your point, Stacey, we just got to hit them in the pockets, because we all win if we all move forward. And I'll close on this. When they stood at the mouth of freedom, if you look at Exodus, and they stood at the mouth of freedom, Pi Hi Harath, when God told them, go back. And when he said go back, he was telling them to move across the waters into a place of freedom. And what he said is, tell the Israelites, Moses said, oh, all you got to do is stand still and watch God work. And God said, no, wrong. Tell them to move forward. Tell the Israelites to move forward. And then moving forward, what we discover is that we all walk together, and we all walk into a place of fear together, but we all walk recognizing that there will be change. But we cannot hold each other down expecting to move forward. If any of us are trying to hold somebody else down, you can't move forward with us. So it requires the community. And we're doing the work, and I'm going to be coming back to you guys to build those relationships so we can get you a part of this initiative too.
You put some of that information in the chat like you offered. And also, Julia, I was, if you wouldn't mind putting the information in about the Maryland bill, that would be great. It is 8 o'clock, and I want to be our time. And I hope you all will be coming back to be with us on Thursday evening. But I'll close with our pledge to be more human. And I think we're living up to this evening, that we need to listen to the historical facts and others' truth and pray. We need to think about what you have learned and believe, question what you think you know and how you can learn more, and pray. We need to speak and share your insights, ask questions and pray. And finally, we need to act and think about what will you do to create a positive change in racial understanding, and pray. And in case some of you won't be with us on Thursday, I just wanted to let you know about what our next gatherings will be after this Thursday, when we continue our talk about health. On December 30th, we will be having a presentation of the African American holiday, Kwanzaa, but this is going to be Kwanzaa for all of us. So please come and join that celebration and of community and family values that can help all of us grow in our understanding of each other. And then in January, we are going to have what is the second annual Reverend Martin Luther King Spoken Word Contest. And this is a contest for 4th through 12th graders. If you have 4th through 12th graders in your congregation, in your family, in your neighborhood, the theme for this session is going to be This Moment in History, My Story. So we want to invite students to just make a 3 to 5 minute recording to share what they're thinking about what's going on in this world today. You know, so they're teenagers, they're middle school students. What will they tell their kids about what's going on today in 25, 30 years? About the COVID pandemic, about Black Lives Matter, about our election, social unrest, income inequality, climate change, and many other things that, you know, what we explored this evening. So there is more information about that, or will be more information about that on our Presbytery website. And if you're just really wanting more information about that, you could actually go to the Hunting Ridge Presbyterian Church website, where we've posted the information about this contest. So
I'm sorry to butt in, but I'm told we may have a question from one of our participants.
Okay, great, go ahead.
Was that you, Martha? I've asked you to unmute. Okay.
Yeah, I just wanted to, I thought Stephanie, is it, could answer whether there is any increase or change in racial and in health disparities if because of the new private emergency clinics like Patient First, whether anybody has any idea whether that the surgent of those kinds of clinics has increased or decreased racial health disparity. Hope I made that clear.
So I think, I don't know if Stephanie's still here. You still there, Stephanie?
I'm still here. It's Stacey. It's Stacey. I'm here.
Stacey.
Sorry.
Well, I don't have any exact numbers or figures on that. So I mean, I wouldn't want to say yes or no. We always know that access is important, but relationship is important as well. And so I know that having FQHCs or fairly qualified health centers have been helpful in our community, have provided care for folks generationally, and so have built up a relationship. But the great thing is many folks are trying to do a similar model and making sure that providers are accessible after hours, so folks don't have to go to the emergency room, and on the weekends. And so I think you should probably pull up a map to see where many of those Patient Firsts are located, if they're in the footprint of where folks would say it is easily accessible. And sometimes it's not just enough being easily accessible in our community, but it's also about relationship. So that's my quick answer to that.
So I'll give another quick response to add to that. The problem is not the facilities such as Patient First and these emergent care facilities. The problem is just the overall general healthcare system. And at night, do this work at CMS where we look at this level of care. And the biggest issue is care is rationed based on income. So if you don't have a job, then mostly you don't have insurance. And if you have insurance, depending on where you go, they don't always take the insurance you have. So you find yourself often being rationed in your care based on copays and doctor's visits and sliding fee scales. And you take a person that has no money and has to decide between eating, cigarettes, and just trying to manage their lifestyle, then they're not going to put that over those things that make them function in a normal day, to go to a facility that charges them and will not see them unless they have either money or has insurance. So they still wind up oftentimes in the emergency room. But that's a great question.
I'm not going to mention again where we work, Dr. Henderson, but if you even just think about what's going on in the world today in the United States with the Affordable Care Act, the whole issue about the Supreme Court and how they would treat that, what the administration now wants to do with the Affordable Care Act, policy. You know, I am a nurse, and I've been a nurse for a long time. And I worked at FQHCs for a large part of my career. Federally qualified community health centers are sliding fee centers where folks who are uninsured can receive health care. And what always impressed me over the years when I was working as a clinician was that these were the best kept secrets in the world. People did not know about them. And I kept wanting to know what drove the work that we did there, who was pulling the strings, what were the policies, who were the policy makers that really impacted who received care. You know, so just going back to the question of the urgent care centers, I think Stacey, you responded to that spot on. Look where they are. They are commercial, proprietary organizations. They're there to make quick money. They're not medical homes for people. They don't build relationship. Even though I know some of them are trying to build themselves more in that vein, they aren't the answer. We really need to pay attention to policy. We need to be politically involved in decision making that's going on about opportunities to receive healthcare. So this is really important. So thanks for that late breaking question. And we're going to close our session today. Please register for the 19th and come back so we can have more of these conversations. And again, kudos and thank you so much to our presenters. I don't know if we can all open our mics and give them all a hand so they can hear us clapping. Thank you so much.
Great time.
Thank you. This was fabulous.
Thank you so much.
Night.
Good night to all.
Good night.
Good night, everyone.
Good night, everyone. Thank you.
Annette, you sticking around?
Yes, I am. And presenters, if you would. Okay.